Acute decompensated heart failure. Epidemiology: 5.1 million U.S. adults over 20 have HF, heart failure. Estimated that by 2030, another 3 million adults will be diagnosed with heart failure. Over 1 million are hospitalized for HF annually.
So this first talk is, like Dr. Estep said, about acute decompensated heart failure. I'm going to mainly focus on the recent updated guidelines and go over some of the mainstays of goals of therapy, and then kind of how we got reduced for those who have a preserved ejection fraction. So patients with heart failure with a reduced ejection fraction, those are patients that have a clinical diagnosis of heart failure with an ejection fraction of less than 40 LV diastolic function. Overall, as the population ages, we have an increasing number of these patients, and right now the lifetime risk of developing heart failure is about 20% for Americans that are over age of 40. There's about 650,000 new cases of heart failure that are diagnosed annually, and over 5 million people in the U.S. have clinical manifestations of heart failure.
Pathophysiology: what leads to decompensaton in unstable patients? Become refractory to oral therapy, diary incursions, NSAID use, other cardiotoxic drugs, medication non-compliance, infections, and other cardiac events. Why hypertension increases? When trying ADHF, you can use drugs that 1. Decrease preload, 2. Decrease afterload, 3. Increase heart rate. And goals of acute decompensation heart failure treatment: hemodynamic stabilization, supports of oxygenation and stabilization, symptoms relief. Diagnostic: clinical signs and symptoms, lab.
Well, they just come in with a little bit of extra volume, a little bit of shortness of breath. But patients who manifest other signs or symptoms, particularly these, are particularly concerning. Definitely cardiology should be involved, and anybody who has heart failure and elevated LFTs or nausea. In terms of nausea and elevated LFTs, we very commonly see in our patient population, patients get referred, patients who have abnormal labs, whether in clinic or in the hospital, and the first line, again, they present differently, they present similarly, and the management in the initial period, as I'll show you, is actually pretty similar. Swan findings with physical exam findings done by experienced cardiologists, and so how do they do? You can see from this, not that well. So this is for the two things that are kind of important. One is whether or not you can identify patients with elevated filling pressure.